Good evening, my friends, my colleagues. Today is the wave 2 of the French Expert Campus. I'm honored to be with these distinguished international speakers, with Dr. Amr Zaki, my friend and head of the department, Cardiology Department, Alexandria University. Do you remember the wave 1 and was done 1 month ago? And this is the newsletter of the wave 1. For this wave 1, just to remember, where we have 3 sessions, and these sessions including Gilman Telesco with his session about the antiplatelet antithrombotics with or without the COVIDs, and Jill and Antoine Affan about the acute coronary syndrome management in the COVID pandemics, and finally Thierry Lefebvre, the third session with the interaction about the bifurcation. The reviewers were 450 plus 3 international experts with 2 national experts, myself and Dr. Amr Zaki. We have 31 countries. This is one of the most important part of this wave, is the number of countries involved. So we have a great honor to thank you all of your valuable participations. Now, today we have a wave 2. We'll start it now and for 2.5 hours. Thanks to Medtronic and AstraZeneca for sponsoring this important webinar. And also the main topics for today is the ACS with high bleeding risk, how do you manage, by Professor Gilman Telesco, the head of the cardiology department in Saint-Pétrier. And then ACS with calcified lesion, how do you manage, by Thierry Lefebvre, head of the cath lab of Paris Sud. And crossroads between guidelines and practice by Professor Amr Zaki, SGLT2 inhibitors, heart failure with without diabetes, myself, and then updates on sudden cardiac arrest and heart failure by Dr. Hagi. Dr. Antoine Affan, the head of the cardiology department of head of cardiology department of Georges Pompidou, will join the sessions 1 and 2 regarding the sharing for the interactive discussions. Dr. Mustafa Nawar will join us in the second session for the heart failure, the head of the EPS lab in Cardiology Department, Alexandria University. Dr. Hagi is one of the famous EPS doctors in Tunis. We choose Dr. Hagi because he speaks French, and also he's an eminent speaker regarding the AICD and CRT, and this could be used in the heart failure patients. So this session is sponsored by AstraZeneca and Medtronic, and the technical part for the preparation by ICOM company. I will stop sharing my screen and then I give the mic to Dr. Antoine Affan. Antoine? Can you introduce the first speaker?
Privileged to introduce Professor Montalesco, who will speak about ACS with high bleeding risk. How do you manage?
Yes, thank you, Antoine. Thank you, everybody. It's a pleasure again to be with you and discuss this topic in the next 15 or 20 minutes. So this is ACS with high bleeding risk, and it's not an easy topic. And I would like to start by a couple of questions here. How do we define bleeding? And this is clearly the first question, and we have several types of definitions. I must say that the BARC definition is probably now the definition that are widely used by experts and in the clinical trials. And I think we could use these definitions also in the daily life. It goes from no bleeding, type 0, to type 5, which is fatal bleeding. And in between, you have incremental seriousness of bleedings. And it's quite easy to remember. And usually we deal with type 3, 4, and 5 bleedings when we want to consider major bleedings for our patients. The next question is more difficult. And We have definitions and it is good for clinical trials, but in the daily life, we want to know how to score the bleeding risk of our patients. And we have had many scores. And this is a problem because none of these scores is good enough to be used in daily practice, I think. And this is a limitation of all these scores. They are not easy to remember for some of them. They use different variables and they are imperfect in the evaluation of the bleeding risk of our patients. In a recent consensus, it was said that high bleeding risk was a risk of bleeding of more than 4% for major bleeding, and a risk of intracranial bleeding of more than 1% during the first year, just to give you the level of risk of the patients. And these scores try to identify the patients at this level of risk of bleeding. And when we say 4 or 5% of major bleeding, this is a big number. This is not a small number. We have had different scores available, and for bleeding, the precise DAPT score is one which has been promoted by the European guidelines. But again, you need your cell phone to calculate this score. It's not always easy because you do not have always all the variables at the admission of the patient, and you cannot calculate from the top of your head this score for your patient. So there are limitations also with a precise DAPT score. The DAPT score itself is a combination of ischemic and bleeding evaluation. It's a different type of score. But we see here also the limitation of these scores. And I must say, when I talk to my colleagues, that most of them, they don't use scores in the daily practice, probably not good enough and too complex. So another way to look at bleeding risk is to say, we know how to define bleeding. We know how to score bleeding, but it is difficult and not easy. Why about just an assessment of the bleeding risk? And this is the first studies, PCI studies, that looked at high bleeding risk patients. And in these studies, starting with the LEADERS 3 study, as investigators started thinking about the evaluation of the bleeding risk in patients, how can we define easily what is a high bleeding risk patient? And we have now, after several studies done for these populations, a kind of identification of the patients at high bleeding risk. Of course, the elderly, of course, the patients on oral anticoagulation, but also patients with organ failure, renal failure, liver failure, stroke recently, patients also with planned surgery, patients with anemia, defined here with a level of hemoglobin below 11 grams. So a number of factors, roughly, as you see, it's 12 factors on this list. It's good, it's easy, but it's not easy to remember. But we start seeing how we can assess the bleeding risk of our patients. I was involved recently in this consensus with our Asian colleagues to define the bleeding risk in patients, especially in the Asian patients, because they are exposed probably to more bleeding than Caucasians. And it is a major discussion in Asia, probably even more than it is in Europe or in North America. And after long discussions, I suggested that we could have something easier to remember for the clinicians, taking what we know, but having an easy evaluation. And I propose this ABO score, easy to remember, A for age, and more than 75 years is, of course, an exposure to bleeding risk. But we said also that more than 85 is a higher risk in this subpopulation. And a reduced life expectancy is also a way to identify high bleeding risk. B for bleeding, because a prior history of bleeding is a very strong indicator for the risk of bleeding. And hemoglobin below 9 grams is certainly a high marker for the bleeding risk. And or for organ dysfunction, and again, this is something we have seen in the previous slides, organ failure, maybe liver failure, renal failure, stroke, but also bone marrow failure with thrombocytopenia. So this is, I think, easier to remember, and I think we can use it probably more rapidly at the bedside for our patients. So what we need to do next is to plan the treatment strategies. And when we think of bleeding risk in ACS patients, of course, there is a side of PCI and radial access, preloading, intravascular imaging. All these things should be discussed in regards to the bleeding risk of the patients. Risk stratification, this is what we said, assessment of the bleeding risk in the patients. Bleeding prevention, of course, it's going to be intensity of the APT, but also duration of the APT and concomitant treatments available to prevent bleedings like PPI. And then you have to do the job. You have to treat the patients. If there is no bleeding, this is fine. Follow the guidelines. If there is bleeding occurring, you need to adjust treatment to shorten the APT, to de-escalate your treatment, sometimes to treat the bleeding without the APT. And this is the discussion that we may have along the way in these patients exposed to bleeding. So let's take a couple of examples. And this is now STEMI in high bleeding risk patients. The first thing we need to remember in a high bleeding risk patient, including in the very old patient, is that thrombolysis is probably not the right way to go. We should propose primary PCI as often as possible in these patients. The risk of intracranial bleeding is very high in patients above the age of 75 and even more above the age of 85. And primary PCI is certainly the way to go in these patients, and we can adjust the APT according to what we have to do in the coronaries of these patients. So we have sometimes difficult decisions for PCI in high bleeding risk patients. Most of the time, the acute STEMI risk is superior to the bleeding risk of our patients because we identify patients at high bleeding risk, but is presenting with an ongoing STEMI, and we need to treat the patients as we would do for another patient, no question about that. But in some cases, we have bleed emergencies, and this risk is superior to the STEMI risk. And we had an example very recently in my cath lab where we had a patient presenting with an anterior ST elevation MI in the middle of an ongoing intracranial bleeding, a huge intracranial bleeding. And we decided after discussions with the colleagues not to touch a coronary artery, which was in TIMI3 flow, with a very tight stenosis on the proximal LAD. I don't know if it was the right thing to do, but actually everything went well for this patient. She survived in the intracranial bleeding, had little neurologic consequences, came back to the cath lab several weeks later, and we were able to reopen the artery in this patient, still in TIMI3 flow, and it was almost 3 months later. So it's still possible to keep these patients without angioplasty, with a TIMI3 flow, and delay reperfusion of the coronary artery. And the third possibility is also is different. It's a high bleeding risk patient. For example, a STEMI in the middle of a surgery, and this patient, surgery is going to be ended. Patient will go to the cath lab. What shall we do? And there is no guidelines, of course. We need to improvise. Balloon angioplasty may be a solution, but very difficult to tell you what we should do for this difficult decision. So all these patients are not the same, and we see that the strategies cannot be the same. What about antithrombotics in these patients at high bleeding risk? If you have a low bleeding risk among these patients at high bleeding risk in general, you would use aspirin, probably one of these new P2Y12 antagonists. You would avoid GPIs for sure, except maybe for bailout situations. And you would use enoxaparin or bavdegalutamide. Both of these drugs have been associated with less bleedings than unfractionated parin. If the risk of bleeding is higher, you will move to aspirin and clopidogrel, maybe 600 milligrams if you think it's appropriate. You may think of having cangrelor because you have a fast onset of action, but also a fast offset of action in case of bleeding complication. And again, use enoxaparin and bivalirudin rather than fractionated parin. And if you have a very high bleeding risk in your patient and you still need to do a primary PCI, aspirin, clopidogrel, low dose, enoxaparin and bivalirudin, and forget everything else. So we need to adjust our treatment strategies according to the presentation of the patient and the risk of bleeding that we have assessed at the time of admission. Let's take the example now of NSTEMIs with a high bleeding risk at the same time. This is all the studies that we have for NSTEMIs considering prasugrel and ticagrelor. And when you need to pick one of these drugs, clearly you're going to select patients at a bleeding risk which is acceptable for this type of drugs. Otherwise, you may want to use clopidogrel, of course. But the first thing to remember is to avoid to overtreat the patients. And when I say overtreat the patients, it's to avoid pretreatment of these patients. And we have a large study here, a randomized study, double-blind study, 4,000 patients saying that pretreatment is associated with an excess of bleeding complications, and it should be even worse in patients at high bleeding risk. ISAR-IAC5 suggests exactly the same. And we will have at the next ESC meeting the WBS study with ticagrelor looking again at pretreatment. So for now, all the data that we have tell us avoid pretreatment in these patients, especially if they present with a high bleeding risk. This is what we had in NSTEMIs, in the ECHO study, in the subgroup of patients undergoing PCI. And as you can see, when you look at CV death, MI, or stroke, there was no difference between those being pretreated and those without pretreatment. And without pretreatment was only aspirin. And when you look at pretreatment versus no pretreatment, there was a large excess. Look at the hazard ratio here for major or minor bleeding. So in a high bleeding risk patient, that would be a terrible mistake to pretreat these patients with a P2Y12 inhibitor. So antithrombotics in high bleeding risk patients, when they present with NSTEMI, I would say at admission, aspirin alone, and that's it. In the CCU, aspirin alone, and nothing else. Wait for the cath lab. Go to the cath lab as soon as possible. Do not delay the cath lab because all the decisions will be taken in the cath lab in this high bleeding risk patient. You will use one anticoagulant drug. Again, we use enoxaparin. You could use bivalirudin. There is less bleeding with these anticoagulant drugs than with unfractionated heparin. At the end of PCI, you may decide clopidogrel or prasugrel according to the data that we have. We need to say that prasugrel can be adjusted in terms of dosing. It is not the case with ticagrelor. And there is a beautiful paper in the Annals of Internal Medicine showing that you have very good results with 30 milligrams and 5 milligrams of prasugrel in these patients presenting with NSTEMIs. You have an advantage here of keeping the efficacy and decreasing the bleeding risk. So two options according to the bleeding risk, clopidogrel or prasugrel, but even prasugrel, you should adjust the dose down. Next, we have to decide for the DAPT duration. What do the recommendations say? They say that in an acute coronary syndrome with DES, BMS, whatever the stent, it's 6 months of treatment. And when we look at this, 6 months is a very long time for these patients at high bleeding risk. When they are medically treated, it's 1 month only. I'm pretty sure that we could do 1 month of DAPT in many patients here with a high bleeding risk when they have a DES being implanted. When we look at the guidelines, ACC guidelines or ESC guidelines, both types of guidelines have evaluated the bleeding risk for spontaneous treatment here. For these patients at high bleeding risk, for example, when they need to go to surgery, here it's, in the ACC EHA guidelines, it is looked at depending on the type of stents. For ACS, which is a question of today, they say 12 months of treatment and 3 to 6 months when you implant a DES, so for high bleeding risk. And the guidelines at the in the ESC say globally the same here, but in these European guidelines, we still mention 1 month treatment for these patients at high bleeding risk. Is it good enough? It's a bit complex. I would suggest to say that for ACS, 6 to 12 months, when you do not have a high bleeding risk, 3 months, possibly 1 month, when you have a high bleeding risk or very high bleeding risk, this is an acceptable DAPT duration. Which antiplatelet to stop? We could stop P2Y12. We have data about that. And you have 4 studies on this slide showing that P2Y12 can be stopped, but you can stop aspirin also. And if you look at all the studies, aspirin removal or P2Y12 removal, you have more studies here that the total number of patients is roughly the same. We have 30,000 patients on both sides. So you can stop one or the other according to what you prefer for your patient. You need to manage bleeding sometime. I will not go into the details of this guidelines, ESC guidelines. It is very intuitive. And in general, I think the physicians do the right thing in patients presenting from a question of trivial bleeding or massive bleeding threatening the life of the patient. I will finish up with a case of atrial fibrillation rapidly because this is a typical case of high bleeding risk because you have an association with oral anticoagulation. The guidelines at the ESC level still say that the default strategy is triple treatment, and dual therapy here is limited to very small subgroups of patients according to the bleeding risk. I suggested that we could say that the default strategy is double treatment here, and only in a certain number of cases you could keep aspirin for a longer period of time, maybe 2 or 3 weeks after stenting. But you may think here that we have lots of these patients deserving aspirin in addition to double treatment with clopidogrel and oral anticoagulation for various reasons. And these various reasons, you have a couple of examples here, can represent a large number of patients. And this is where we have issues in determining what patients should receive aspirin for more than the hospital phase. We have had 4 big studies, but none of these trials was powered for efficacy, and this is where we have an issue. Just to say, what is the price to pay if you want to stop aspirin early, as it was done in a randomized fashion in one of these studies, which is the Augustus study. The price to pay is right here, and you have the hazard ratios here. You will see a doubling of stent thrombosis, probably. You will see an excess of MI. You will see a slight excess of urgent revascularization. And this is a 20% increase globally of ischemic events. This is represented here for stent thrombosis. You may say, this is a rare event. I don't mind about stent thrombosis. Major bleeding is a more frequent event, yes, but in Augustus, 70% of these patients with a stent thrombosis and an MI, and 40% of these patients died within 24 hours. So yes, it is a rare event, but yes, it is a very serious event. So this is what I wanted to say. In this meta-analysis, we looked at these 4 studies, including also VERST in the meta-analysis, and you see the price to pay in terms of MI and stent thrombosis. You see here an excess of events when you have aspirin on board. But look at the 4 studies. Look at the points of these 4 studies, excluding VERST. All these studies are on the right side of the line of identity. So it's not enough to get power to definitely conclude, but all 4 studies showed an excess of MI and an excess of stent thrombosis. It was small numbers, it was not significant, but it was reproducible from one study to the other. So which antiplatelet shall we drop? All these studies have removed aspirin, but you could decide also in some circumstances to remove clopidogrel. When shall we stop this antiplatelet agent if we want to stop it? Even when you look at the 4 studies, it's difficult to say. Look at the 4 studies, 72 hours, 120 hours, 15 days, 5 days in interest. So all types of scenarios. So you could stop it. The day after PCI, you could stop it 2 weeks later. And this is where you need to decide according to the type of patient you are facing. So my conclusions are going to be very simple. In high bleeding risk patient presenting with a STEMI, you may prefer primary PCI as often as possible and be conservative with antithrombotics, but try to treat the patient and reopen the artery. In high bleeding risk patients with NSTEMI, please avoid pretreatment. These patients should not be pretreated with a P2Y12 inhibitor. Just keep aspirin until you get a patient in the cath lab and be conservative in terms of PCI also. Do not go for revascularization of all the arteries when it is not needed acutely. High bleeding risk, reduce the APT duration. We all do that. It can be 1 month in some circumstances. And high bleeding risk, select the antiplatelet agent to drop. And you can do both. Drop aspirin or drop clopidogrel according to the situation. If you have a GI bleeding risk, you may want to stop aspirin. If you have other situations, you may prefer to stop clopidogrel. In the AFib case, I must say all the studies dropped aspirin, so it's probably more relevant to drop aspirin if it is feasible. Thank you very much for your attention.
Thank you, Jal. Okay.
Question?
Yes. Amr, start the question. Okay.
Okay, Gilles, it's a very, very nice presentation. And it's a very difficult topic also because in STEMI patient, it's very difficult to propose for the scoring because usually the patient arrives at the hospital if he has taken, for example, 600 milligram clopidogrel from anywhere, then automatically in the emergency room, they shift and they give them 180 ticagrelol without the scoring system. So what's your comment here? It's very difficult.
I think in STEMI, most of the time, you need to bring the patient to the cath lab, reopen the artery, at least with a balloon, most of the time with a stent, and use 2 antiplatelet agents. And it's probably acceptable in 90% of patients. There are some cases which are difficult cases, just like the one I mentioned. You know, when you have an intracranial bleeding, it threatens your life also. So we decided not to touch the artery. I was not sure it was the right thing to do. At the end of the day, it was the right thing to do because the patient is alive, I was able to implant the stent very easily 3 months later. I was myself very surprised by the fact that this artery, 95% stenosis, a thrombus at the beginning, was still open 3 months later. But that's what happened without antithrombotics at all. I cannot say one case should be the rule for every patient because I don't know what is the truth. But in most STEMIs, yes, we need to reopen the artery, I think, and treat with 2 antiplatelet agents. If it's too much, even clopidogrel single therapy is probably possible in many patients.
Jill, regarding it's a wonderful lecture as usual. It's very difficult for anyone to compete with you in this kind of antiplatelet. But regarding that, you didn't mention 2 important points. You said that I'm going to speak about the de-escalation, but you didn't mention the second that you forget about the type of stents. I don't know why they ignore the stents because the claim about the biofreedom and Onyx one. You said one stent. I think it's one of your slides. It's Onyx one, but one Onyx one, Onyx Global, and Onyx Clear. You have speculations now about if you have these type of stents, you can only make it over 1 month up to 3 months for that for the ACS patient. What do you think?
First, I think I mentioned de-escalation. I didn't have time to show all the possibilities of de-escalation, but of course, it was mentioned. Type of stents, yes, you're right. But if you look very carefully at what's going on, all the companies almost try to conduct a study or a registry to show that it's possible to use their stent with a short DAPT duration. It has become a way of marketing the stent. So I agree some of the stents had better studies than others. Onyx one is a good study. and it is a recent study, and it shows perfectly that you can use this stent with clearly a short duration of DAPT, but I think it's feasible with most of the last generation DERs. We have also, at least one study I'm aware of with 2 weeks of DAPT and not 1 month. It would be very interesting to look at this study because we know that the risk of stent thrombosis is mostly during the first 2 weeks, and it may be a successful study. Now, even if you see a positive study with 2 weeks of DAPT, be very careful because transposing this message to all the patients, I think, may be a mistake.
Antoine.
Yes, I thank you very much, Gilles, because again, as you mentioned, Mohamed, it was very complete, very balanced. I'd like to focus on the point that you underlined regarding the non-STEMI and the loading dose. I think this is a problem for at least us in France, because all of the patients are preloaded by the mobile medical units. And this is a message which is not so much by our colleagues. And the second point is, why is there a difference between the loading dose in non-STEMI and in STEMI? Is it proven that loading dose is mandatory for a STEMI patient?
First, I think you're correct. Many physicians, when they see the NSTEMI patient, not only in the mobile intensive care units, but also in the emergency room and also in the CCU in the middle of the night, they tend to load the patients with everything they have on board, aspirin, P2Y12 inhibitors, anticoagulation, and we have all the patients on triple treatment when it is not needed. They will go to the cath lab on the next morning. Nothing is going to happen during the night. And I think this is a mistake. But we need to educate the people and say again and again, don't rush for triple treatment in these NSTEMI patients, especially the elderly. Wait for the next morning. You don't have to rush. Nothing is going to happen in the middle of the night. That's fine. Give statins, nitrates, beta blockers, whatever you want. But don't give triple treatment to these patients. We need to educate our colleagues. And for the next point, yes, the loading dose is a question. In STEMIs, we need to use what is rapidly effective and at the maximum dose. To be effective as early as possible. So it is a full loading dose of prasugrel, ticagrelor, crush the pills if you can, use cangrelor if you can pay for it. We have ways to get inhibition at the time of PCI. For NSTEMIs, it is not the issue. We don't need this rush, and clearly you can use your loading dose, and you can also adjust your loading dose down with 30 milligrams. We use 30 milligrams in the COAST study. We use 30 milligrams in the Trilogy study. And this is, we know this loading dose works very well. You reach exactly the same plateau. With 60 milligrams, actually you have an overshoot of platelet inhibition. For ticagrelor, there is no question because they didn't study a reduced dose for loading. They studied a reduced dose for maintenance therapy, but not for loading. So you have to use 180 milligrams. So, but I think the main message is that we probably, all of us, overtreat NSTEMI patients, especially the elderly. All of them are high bleeding risk patients, and we need to be careful.
Eric, you have a question to Gilles?
Yes, I have one question. Thank you very much, Gilles. I think it was excellent and very difficult to do this kind of talk in 20 minutes, but it was excellent. I have one specific question about the old patients, because we learned in many studies that aspirin is associated with a high risk of gastrointestinal bleeding in these elderly patients. So when you take the decision to stop one of both DAPT, aspirin, or ticagrelor, or prasugrel, or clopidogrel, or etc., does you take that into account, the age of the patient, to stop? Do you stop more aspirin than the others when you have to stop at 3 months, or 6 months? What is your current practice?
It's a very good question. I tend to stop aspirin very often, more than clopidogrel when it's time to stop one antiplatelet agent. And we need to remember that the first study for clopidogrel 20 years ago was against aspirin. And it was a Capri study. And there was better safety. And there was a beautiful reduction, 27%, if I remember well, of GI bleedings. So when you are concerned about GI bleeding, stop aspirin and keep the other. If you have ticagrelor on board, it's a different issue because we don't know exactly what is the weight of aspirin versus ticagrelor, but it's also possible to stop aspirin, as it has been done in several studies now, and to keep ticagrelor. But in high bleeding risk patients, most of them, they wouldn't have ticagrelor, they would have clopidogrel.
Yeah, I fully agree. So do you do the same for TAVI patients? You stop more aspirin than clopidogrel?
Yeah, we tend to be conservative for TAVI patients, especially with antiplatelet therapy. As you know, we have a study that will be presented very soon, the Atlantis study, where we imagine that there is another possible strategy, which is a NOAC rather than antiplatelet therapy. And we have studies showing that the safety of the NOACs that we have used, Apixaban, in Averroes, the safety was exactly the same as the safety of aspirin monotherapy. And I think in TAVI it's going to be more effective. We'll see. For TAVI, the question is fully open. I think nobody knows exactly what we should do. But this issue of, valve thrombosis, of HALT, of RELM, is not solved. What we know from several studies now is that anticoagulation tend to work better than antiplatelet therapy.
There is a question from the audience to you. What about ticagrelor compared to clopidogrel in rate of bleeding? And that you said that you can give the patient at the 1 year study prasugrel, which is known to have more bleeding than the other two antiplatelets. How do you differentiate and your choice of the using? I know that they're more potent than clopidogrel, but there's a high risk of bleeding. So you choose those is the lesser bleeding, which is with clopidogrel. What do you think about the choice between the three?
Both prasugrel and ticagrelor are more potent than clopidogrel, and they expose patients to more bleedings. For example, I mentioned rapidly the Radiol study. In Radiol, if you look at a group of patients, large group of patients that had ticagrelor versus a group of patients that had clopidogrel, there is a big difference in terms of bleeding, in association, of course, with anticoagulation. So you see this difference in high bleeding risk patients. Using one of these new P2Y12 inhibitors is going to be associated with more bleeding than clopidogrel. So I would not recommend to use this type of agent in high bleeding risk patients. We have clopidogrel. This is fine. Let's stay on the safe side.
Okay. Thank you very much, Jel, for this wonderful lecture and questions. I think we can come to the next Amr. Zaki. Yeah. Thank you, Jel. You'll be with us.
Yes.
It's my pleasure now to introduce Dr. Thierry Lefebvre, one of the eminent and most interesting interventionalists worldwide, and we learned from him and from all the EuroPCR team during the last 20 years. Thank you. Please, he's going to talk about acute coronary syndrome with calcified lesions.
Thank you very much, Arm. Thank you for your nice words. So I will talk about ACS with calcified lesion, how to manage. As you know, calcification impacts the outcomes of patients after coronary stenting. There is many studies. I would just mention one, which is meta-analysis of Horizon and Acuity from Dr. Généreux, who showed that when you have calcification, and it's related to the importance of calcification, you have more deaths, more cardiac deaths, more MI, more TLR, more MACE. And there is studies also showing that you have a higher risk of stent thrombosis. If you look at the meta-analysis of the independent predictors of event in this study, you can see that all these factors are independent. So calcification is associated with death, cardiac death, stent thrombosis, and ischemic-driven target lesion revascularization. So calcification is something very important and which should be identified. And it's not so simple. We learned that when you have more calcification, you have less expansion of the stent. Of course, it's clear. And this study from Wang is very nice because it showed that the predictors of poor extension are the calcium angle in the vessel, the thickness, and the length of the calcium. And this is, of course, associated with poor stent expansion. You can see that stent expansion, when you have severe calcification, in 86%, as compared to 94% when you have non or mid calcification. So why optimal stent expansion is so important? Because you have better rheology in the vessel, you have uniform drug delivery, you have a low risk of stent thrombosis, as you have seen, and lower risk of TLR. So that's why it's a strong recommendation from ESC to do intracoronary imaging. You have restenosis to identify the predictors, and usually it's because poor stent expansion. What is the problem with this lesion is that we see more and more patients with calcification because we are treating people who are getting older. The calcification are underestimated by angiography. Predilatation is more difficult. Stenting is more problematic, especially in terms of deliverability, the risk of losing the stent, the risk of mal-deployment, mal-expansion, risk of damaging the polymer, which will induce restenosis, and also the risk of complication because you go to high pressure, the risk of perforation. This is a very interesting study from Wang, which showed that by angiography, you are able to predict less than 50% of patients with calcification. So the angio is not a good tool to say that you have calcification. OCT and IVUS are better, but not perfectly. So it's 90% with IVUS, a little bit less with OCT. I would add some thing which is a stent boost, which is very useful to identify calcification. So when you use a balloon with two markers, you are able to detect calcification at the level of the lesion. In ACS, there is a study from GIA which is very interesting, which showed that, of course, the majority of patients have plaque rupture, but there is a lot of patients who have erosion, about 30%, but also 8% of the patients had calcification nodules, which make a more difficult procedure, and the nodules are not necessarily at the level of the culprit lesion. It could be proximal to that and may pose a lot of problems during the procedure. So how to deal with this calcification lesion? Very important to assess the vessel and the lesion, the length and the thickness of the calcification, the vessel diameter. Preparation is, of course, as you know, very important. We have a lot of tools. I will not go into more detail, but just show some examples. And it's very important to obtain at the end an optimal stent expansion and stent apposition. So use stent enhancement. It's very useful to detect poor stent apposition. Non-compliant balloon, OPN, NC balloons that are very useful, and now I think it's available in Egypt. Better to undersize the balloon when you go to high pressure because you have resistance, because if you bigger balloon, the risk of perforation is very high. And remind that time is your friend. And I will explain why. So this is an example of a patient with acute coronary syndrome who had this ostial lesion of the right coronary artery. It's a big vessel, and you can see clearly that there is a lot of calcification at the ostium. In this case, we have pre-dilate with a non-compliant balloon to see that there is no residual waste with a 3.5, but remember that this vessel is very large, it's close to 5.0. So we deploy a stent, which was a 4.5, 20, and during a study that we have done many years ago, we look at the size of the stent at 5 seconds, 15 seconds, and 25 seconds. And you can see that stent expansion came to 0.83 to 0.88, and you can see the minimal and maximal and mean diameter of the vessel. So by time you increase the size on the apposition and expansion of the stent. So this is the result with a 4.5 stent. Now if you do again a stent boost, you can see that we have some recoil. So we came from 0.88 to 0.82 stent expansion. Of course, the result looks very good, but you can see that the deployment is not perfect. So we came back with a 5O balloon, 21 atmosphere for more than 30 seconds. And now if you make the stent enhancement, we can see that we have a very good expansion, 0.92. So what we learned with this study is that we see this paper was published many years ago, that by time you increase the minimal stent diameter, you increase the maximal stent diameter, and you increase the average stent diameter and stent expansion. So this is a very important message, and I recommend you to do at least 30 seconds inflation or several times 10 or 5 seconds if needed. Second example is a patient with undilatable lesion, and this sometimes occurs. So this is a patient coming from acute coronary syndrome. He had a chronic occlusion of the right, and you can see these lesions, this lesion of the mid-LAD, which looks relatively simple. There was a stent which was implanted distally many years ago, which is okay. But you can see already that there is calcification of the mitral annulus and calcification of the aortic valve. So you can anticipate that maybe this lesion will not open simply. So in fact, we are not able to go with a 2.5 non-compliant balloon. So we had to use a 1.5 balloon to predilate, and you see that the balloon was not open. So we moved to a cutting balloon, and you can see again at very high pressure for cutting balloon, 18 atmosphere, there is still a waste on the balloon. So we switched to rotablator, 1.25 BAR. And again, you can see that with a non-compliant balloon, we have not a full opening of the balloon at high pressure, 22 atmosphere. So the operator saw that putting a stent will be okay. And I think it was a mistake. So now this is a stent, 22 atmosphere, and you can see that the distal part is fully open, but the proximal one is not. So what can we do now? I think it was a mistake to decide to put a stent while the balloon was not fully expanded during predilatation. So we use, and the solution today is OPN NC balloon. So we use a 2.5 going to 40 atmosphere. You know that we can go up to 50. You can see that there is still a waste after 45 seconds of inflation. So we deflate the balloon and then inflate again, and going from 40, 41, 42, and at 42, the stent expanded. So very important message that you can go up to 50, but when you are at 40, you can go slowly and take time again. So this is the final result with a 2.5 OPN NC balloon, and you can see that it's not oversized because it's really a non-compliant balloon. A third example is the presence of calcified nodules, and this is sometimes very difficult to treat. So this is another patient, a little bit younger, but he had a chronic renal failure, and you can see that there is a calcified nodule here and a distal lesion of the bifurcation between circ and marginal. So in this case, I think it's quite impossible to treat this kind of to stent this kind of distal lesion without a guide extension. So we decide to use a large extra backup guides, 7 French, extension catheter, which is 6 French, because we can treat a bifurcation with 6 French. So rotablator was used. A non-compliant balloon, 2.75, was used to predilate the proximal lesion, the mid lesion. Then we wire the distal bifurcation lesion, deploy a stent, exchange wires, do kissing balloon inflation, and then stent the proximal part of the lesion. And you can see that the guide extension was very useful to be able to put this stent distally and to put this long stent in the SOC lesion. So this is the final result, which I think is very acceptable for all the lesions. And clearly, without a guide extension, you cannot treat this kind of patient. And the last case is acute coronary syndrome is a very elderly patient. So it's an 85-year-old woman, still active, who had hypertension, dyslipidemia. She was a previous smoker, and she was admitted for acute coronary syndrome. The day after the admission, she had an echo which showed the severe aortic stenosis, 0.65 centimeters square. Renal function was not very good. And we have done the coronary angiogram, and you can see that the left was okay, but you can see this very calcified lesion of the ostial right with a big, I don't know how to say that, big nodule, or very big nodule of calcium. This is the left coronary system, which is okay. And you can see again that there is calcification of the aorta, calcification of the mitral annulus, and calcification of the proximal right. So we had a long discussion about this case because we thought that it will be better to treat this lesion because it was an acute coronary syndrome and she had it's a dominant right coronary artery. Treat this lesion, but without using rotablation, because if we have a slow flow or no reflow in this vessel with a severe aortic stenosis, it could be a catastrophic issue. So we start with a GR because it's ostial lesion, and we cannot use an Amplatz guide, for example. So, and we have predilate with a 1.5 balloon, which was able to cross. I was not sure. So this is after predilatation. So we can see clearly this calcification. And then we decide to use shockwave technology. So it was relatively easy to put the balloon in place. And we start with a 3.0 balloon, and you can see that the first inflation has 4 atmosphere, and then we deliver 10 pulses. This is after 80 pulses, so 8 runs of 10 pulses. You can see that there is still some residual lesion. So we move to a shockwave 3.75, and this is after a 5 run of 8 pulses. And you can see that now the balloon is fully open. So then the procedure will be relatively simple. We use a stent 3.5, which was positioned in the lateral view. Then deploy the stent. You can see that at relatively low pressure, the stent was fully open. There is some residual lesion here, but very little. So this is the result. We have done a stent boost, and you can see that the proximal part is not fully open. So we decide to use a 4.0 non-compliant balloon, high pressure, and this is the final result. Of course, you can see distally there is some accordion effect due to the tortuosities, but you can see it looks relatively small at the beginning of the procedure, about 2.5. Now is a very big vessel, so very important for the patient. And the TAVI procedure was done a few weeks later. So my conclusion is that the calcification lesions are underestimated by coronary angiogram, so very important to look carefully at the angiogram, to use a stent boost or stent, other stent enhancements. CT scan can be also useful, and very important when the patient had the CT scan before the procedure to look at the CT scan because you see the calcification. This calcification have a strong impact on stent expansion and therefore on clinical outcomes. Intracoronary imaging is very useful, but in daily practice is not frequently used. Careful angiographic analysis is crucial before and during the procedure. And of course, optimal support is very important. So start with a good support with a guiding catheter, but use also guide extension because it's very useful. And remember that time of inflation is your friend. Thank you very much.
Thank you, Terry, for this wonderful lecture as well. I have some comments on you. For our attendee these webinars, we have two other experts or just trying with doing some of the not all maneuvers of doing decalcifications. Your lesson to them that don't do it ad hoc first. You take your time, look at the angiogram, spend time, and take a decision with even the experienced, and then decide what you do in your car lab. So in your training for your residents for this patient amount of calcium, you said to them that this is a moderate calcium. Do you think that, as Antonio Colombo said, came to us for several times in gym in Egypt and said that when you think about rotablator, go for rotablators. This is Antonio, but in your center, the use of rotablators or orbital atherectomy or shockwave, depending on the amount of calcium or depending that the expertise of the patient, or you start by step by step. I mean, you start by non-compliant balloon, then OP, and then you cutting or scoring, and then you go for rotablators. How can you manage in real life?
Yeah, I think it's a complex discussion, so it depends on many parameters. Of course, the analysis of the lesion is crucial. So, for example, if you have a lesion of the distal right, which is a culprit lesion, but you have a lot of calcification all along the right, probably the best way to solve this issue is to start with autoablation and guide extension, in order to be able to reach the distal right and to deliver the stent at the right spot. Then it depends also on the clinical situation of the patient. For example, if you have a patient with a low ejection fraction, multivessel disease, left main disease, and right coronary disease, and the patient cannot have surgery, using rotablation of the right, for example, which can be a problem, because if you have a slow flow or no reflow in the right and the tight stenosis of the left main, then the patient can go in cardiogenic shock. So in this situation, alternatives are very useful, like shockwave technology, for example. But with a shockwave, you cannot treat a long lesion of a long calcified lesion. You can treat a relatively short lesion. So I think it's very important to, as you said, in stable patients, don't do ad hoc. Take time to analyze the lesion, discuss with your colleagues. Should I use, and I agree with Antonio that if you think about rotablator, probably you should use rotablator, because you never regret to have used rotablator, except sometimes. But you regret not to have used rotablator in many cases. So usually I start always with a non-compliant balloon just to touch, to make a palpation of the vessel. And if you see that the lesion expands with non-compliant balloon at acceptable pressure, I think it's you can avoid using other devices. So it depends on many parameters. So it's not simple, but the most important is take time to analyze carefully the lesion and discuss with colleagues.
Yeah, it's very, very, very nice presentations and stepwise illustration of how to deal with calcium. But my question is for you also. The IVUS now has been less and less being used in our department in the ICC in Alexandria, and we are depending on the stent boost. We are going okay with the calcium like that?
Yeah, I agree with you. For example, in my center, the use of rotablation is about 5% of the cases, so not a lot. Intracoronary imaging is about 5% too. So we don't use a lot. In the US, they use IVUS in many cases, and they said when you are not able to cross with IVUS, you need rotablation. Okay, but then you have used IVUS and you are not able to cross. So I think you can anticipate that by analyzing the lesion and take time. The problem of IVUS is the cost. We have this issue in France too. It's not reimbursed. So IVUS or FDI is not reimbursed. So it's a big issue. So we have to learn when you should use intracoronary imaging. Of course, we should use it sometimes, but not in 30 or 40% of cases.
Antoine.
Thank you very much, Thierry, because it was again very balanced. And you introduced the shockwave technology, which is not so well known. I agree with Mohamed that in my case, I am very fond of rotablator, and I think there is a kind of worry and threat in the young generation regarding rotablator, but it really helps to avoid complication by rupturing the arteries and so on. I wanted to totally agree with you regarding the time. I think it's absolutely critical. I give the example. When you push a big car, it will take few seconds before the car starts to move. And as long as you are brave enough to still carry on pushing the car, it will finally move. In this very calcified lesion, when there is something that I use, which is very simple, which doesn't cost anything, it is simply your inflator. And when you have reached 20, 25, and that balloon is fully inflated, and then you can manage the safety of your inflation by simply looking at a slight decrease in terms of pressure, 1 to 2 atmospheres, 1 to 2, yes. And since we know that pressure volume is constant in the system, if the pressure is decreasing, it means that you have got some result. If in contrary, you, despite having been able to go to 20, 30 atmospheres and it doesn't move at all, I would discourage to insist, and I would rather go to a technology like a rotablator or shockwave or whatever is friendly use in your cath lab.
I fully agree, Antoine. So this is what we are doing. In fact, we inflate the balloon at the pressure that we think is a good one, and then we take time and look at the pressure. And sometimes after 20 seconds, you see the pressure doing that, and you know that you have expanded the lesion. So I fully agree with you. It's a very useful technique, but we have to take time. And yes. I explained that to my fellow. So I push their shoulder like that, and they move. But if I do that, they don't move. So it's just because you push slowly that you are very strong. If you just do that, you are not strong. So so this is a technique that we are using, and I think it's very useful.
Gel, you have any question?
Yes, it was a beautifully done presentation. I liked it very much, Thierry. And I feel like we are old guys here, and we knew times when we inflated the balloon several times, sometimes several minutes, and the young generation, they just want to expand the stent in 10 seconds and go away. And I keep saying this is not the right way to implant stents, and we need to hear you to say it again and again, that we need to take time to expand the stents correctly. And this is true even without huge calcifications. My question is the following. When you have limited calcifications, how do you choose between rotablator and shockwave? And second question, if I can, does it happen that you use a shockwave after stent implantation because you're not fully satisfied of the stent expansion?
Yeah, so a decision between rotablator and shockwave is very complex. Shockwave is really a powerful technique. It works in the vast majority of cases, but you cannot treat long lesions because you can do only 8 series of ultrasound with one balloon. So if you have a 40 millimeter lesion length, you need 8 balloons, or maybe at least 4, in order to be able to do that. So then the cost will increase dramatically. And today, the cost of shockwave is higher than rotablation. So it's a big limitation. On the opposite, when you have a calcified nodule, for example, you have a calcified left main, ostial lesion of the right or the mid-right, it's very useful. So now we are using more and more shockwave in calcified left main, for example, because you have a very good stent expansion of the stent. I hope that the price will continue to decrease, but today is still very expensive. This is a main limitation.
Yes, there is a question from the audience to you. Do you have a stent prediction of this kind of calcification? I mean, this stent with high radial force is more for calcified lesion than those with thin struts. Did the struts influence the deployment as well, or the radial force itself?
Intuitively, I would say that with thin strut, we'll have less expansion of the stent, but there is a randomized study which will be published soon, comparing a thin strut stent to the Abbott stent, and there was no difference. It's a big study with a lot of patients, and in terms of clinical outcome, there was no difference between both. So I don't know, but I tend to use a stent with no thin strut when there is calcifications.
Okay, thank you very much, Terry, for this wonderful lecture and interactive discussion. And you with us. I'd like to introduce my colleague, my friend, Dr. Professor Amr Zaki, Professor of Cardiology at Alexandria University and the head of the department, about crossroads between guideline versus practice. Amr?
It's Dr. Sobhi, it's my pleasure to be with you here to share this. This presentation with you. I'm trying to. Okay, it's okay. Okay. My talk today is going to be in link with the previous eminent 2 speakers, and it's difficult to follow them. But I would like to share with you the crossroad from guidelines to practice in acute coronary syndrome. And I'd like to present 4 cases that may be illustrative. Are we strict to the guidelines? Sometimes we are out of the guidelines. So let's go rapidly because it's long cases. Our first patient is a male patient. He's age 67 years. He presented 10 days earlier in another center with acute coronary syndrome non-STEMI. As a risk factor, he's diabetic, hypertensive, and dyslipidemic. ECG is still showing ST depression in precordial leads and echo preserved ejection fraction with anterior hypokinesia and normal lab test except of increased troponin. The coronary angio has been done, and in other center. As you can appreciate, there is a left main, there is a LAD lesion, heavily calcific subtotal occlusion of circumflex. And as you can see, the diagonal also, the LAD is a little bit calcific, but the circumflex is heavily calcific. You can appreciate from the angio here, the diagonal subtotal occlusion. Maybe it's not a very big diagonal, and the circumflex is underperfused also. The distal the RCA showed posterolateral lesion of intermediate significance. It's about 75% lesion. And the ejection fraction was normal. Then let's go to the guidelines. The guidelines ordered us to do the STS score and Euroscore for the CABG for surgical risk, and for the PCI syntax score should be done. And in this patient, syntax score was 26, which is intermediate syntax score. The Euroscore for mortality was 3.5, which is low. And actually, the patient has been sent to surgery, but why? Because the guidelines, the left main disease with intermediate syntax score between 23 and 32, it's class 1A for CABG surgery, and for PCI, it's 2A. Here are factors that favors, we are accustomed with this figure, custom PCI, and those in favor of CABG surgery, and our patient lies in the CABG surgery because he's diabetic with a multivessel disease and severe calcification. But the patient preference, he denied surgery completely and refused it, and he came to me, please try to help me. And I sympathized with the patient. I start with the diagonal. The diagonal is less calcific, and it yielded with a non-compliant balloon. The LAD also followed. And then long stent is 3/38. And then doing the kissing and post-dilatation with 3.5 balloon. And then this was acceptable result. We didn't want to stent the diagonal at this point. And then we moved to the circumflex. And the circumflex, of course, Antonio Colombo has said, when you think about rotablation, just do it. We started the balloon, but I think didn't work. To go for small balloon or body wire or supportive catheter or rotational atherectomy, of course, rotational atherectomy is our choice. And this, I choose 1.5 BAR, not 1.25 for economical reason, and not to entrap the 1.25, but the 1.5, as you can see here, it couldn't cross. After several trials, and this has happened, it came out all of the system. So what to do? We moved to the 1.25, and it did cross. And after 3 passages, we moved again to the 1.5, and actually it was astonishingly that it couldn't pass either. So I had to move once again to 1.25 for several, and then it passed. And after that, it's easy job. We did the stent to the circumflex, and then we went to the left main with the classic guidelines to do the mini crush at that time. It has been done in 2016, 5 years earlier, and then the pot with a 4 balloon, and this was the final acceptable result, and the diagonal was quite good. The patient is following up with several stress tests, and actually he didn't want to come to the EL to be done. The stress test is negative up till now. So this is the final result. I think it is an acceptable result. Our second case is an elderly patient, is a little bit elderly. He's 76, presenting with a non-STEMI lasting for 48 hours. He presented with systolic murmur and fine crepitations and hypertensive. So he's in heart failure as well as mild to moderate mitral regurgitation as revealed by the echo. There was infralateral severe hypokinesis. His past history is irrelevant as regards ischemic heart disease. He had cholecystectomy and prostatectomy earlier. His risk factors was hypertension, dyslipidemic, and ex-smoker since long time ago with dynamic STT changes in the inferior leads. And going from his angio, as you can appreciate from the radial approach, there is circumflex occluded, as well as the ostial left main was not, while engagement, there is shutdown of the pressure, and the LAD is heavily diseased, very long atheroma. You can appreciate the ostial LAD, and the right coronary was small. It's codominant, okay, but it's small artery. So our decision here, the syntax score also here was 31, but the patient presented with a high risk non-STEMI. Remember that he's in heart failure. We took him to the cath lab under CPAP and still ongoing pain and fine crepitations with mild to moderate mitral regurgitation. So whether to send the patient for CABG surgery or the heart team or go for the PCI, and which the culprit or complete. Because of the emergency here, we decided to go and open the circumflex. And as I appreciated, I took a wire. It was pilot 150 because I anticipated a little difficulty, but it crossed, and then changed to BMW wire and then go easily opening it. Maybe the stent is a little bit oversized. We follow the advice of Dr. Lefebvre by continuous take our time and go to the pressure bit by bit. So now, would you go for complete? Would you go for physiological assessment? There is still a lesion up in the stent and the proximal circumflex. Remember the left main lesion. What about physiological assessment? And here we'll go to the guidelines, and the COMPARE acute trial has randomized nearly 900 patients in multivessel disease in STEMI patients. This is a high risk non-STEMI. 1/3 of them, the FFR guided complete revascularization of non-infarct related artery, and the other 2/3 were infarct related artery only treatment and blinded FFR of non-infarct related artery 45-day treatment window. And let's compare the results after 3 years. You'll find the MACE is less in the first group, significantly less mortality, cardiac mortality, but this was not significant, less myocardial infarction, and most importantly and significantly less urgent as well as elective revascularization in the first group with complete revascularization. So we did go following this trial, and we pre-dilated the LED. There is a very long stent. This is, I think, lines 48, 3x48, Science Expedition. We adjusted it. We landed here in the proximal LED. We didn't want to cross over with this. We will cross over with the stent of the left main. So we landed in this area, and this was a very good result. And remember, there is another lesion just distal to the stent. Take another view. Here it is significant. We can't leave it like that. Of course, we are not using FFR for economical reason, and in acute setting, I don't think it's important. We did a stent here, and it's quite good. And this is the stent for the left main by crossing the circumflex and finishing by pot, then kissing, and then pot once again. And this was the result. For an elderly patient, we left the OIM, we left some insignificant. How for long? Because this has been after 1 year, the patient was on ticagrelor 180 milligram plus aspirin, and he asked me for how long should we continue. Remember, he's 76 years old. And let's go to the guidelines. In patients with MI and high ischemic risk who have tolerated DAPT without a bleeding complication, ticagrelor 60 milligram twice a day for longer than 12 months on top of aspirin may be preferred over clopidogrel or prasugrel. Why? Because of the Pegasus STEMI 54 study. They randomized ticagrelor 90 milligram twice daily plus aspirin, ticagrelor 60 milligram plus aspirin versus placebo plus aspirin, and follow up for 12 months. But this was in any patients with had previous MI. And let's see the criteria of high-risk features. And our patient is in the high-risk features of that. Age above 65 years, which is our case. The patient is 76 years. Diabetic, he's not diabetic, our patient. A second prior spontaneous MI, he didn't have. Angiographic evidence of multivessel disease, which is our case. So we have just one of the high-risk mandates expansion of the dual antiplatelet therapy. And why? Because there is less primary endpoints in both the 90 milligram ticagrelor as well as the 60 milligram, with less bleeding in the 60 milligram. And this for the first time in international guidelines, the European Society of Cardiology guidelines in 2015 has mandated to give ticagrelor 60 milligram considered up to 3 years in STEMI patient. So we did continue with this patient. We shifted to 60 milligram. Our third case, maybe this is out of the guidelines a little bit, but it's very elderly and frail patient. She's 86 years, presenting with anterior STEMI. Only risk factor is hypertensive, and the ECG showed ST elevation from V1 to V4. The echo showed anterior severe hypokinesia with ejection fraction of 45 and moderate renal impairment. So the guidelines told us to go radial, but I failed here to cannulate the radial artery. I didn't spend too much time. It was heavily calcific. And as you can appreciate here, we shifted to the femoral, and this is her LAD, heavily calcific LED, then followed by, I think, a lot of thrombus. And the right coronary was small, non-dominant. So the patient is an MI, continuous pain. So the strategy here, we've seen Dr. Thierry has shown us a lot of problems with the calcific lesions. Here we have heavily calcific lead, age is 86, thrombus on top of calcification, to aspirate or not, and antiplatelets, which beside aspirin, whether you use G2B3 inhibitor or not, and what about the anticoagulant. And this comes the ticagrelor in the elderly patients above 75 years of age. So ticagrelor reduced myocardial infarction, stroke, and cardiovascular death for these patients above 75 years without increasing in major bleeding risk. So ticagrelor is favorable here. What about the kidney function? And we have our patient has moderate renal impairment, and ticagrelor is chronic kidney disease patients with creatinine clearance less than 60 is our patient today. Ticagrelor is superior than clopidogrel in patients with CKD without increasing in major bleeding. So it's safe to use the ticagrelor here. And we give the ticagrelor. Actually, it was very difficult crossing. We used the pilot 50 here. It's crossed. And then we had the idea that to go and clean the artery a little bit. I know that I would never pass, but we had several passages with the aspiration caster, and this was the result after aspiration. Yeah, we had TIMI-3, and actually the patient chest pain has subsided up there. So we calmed down, and we are now planning for the policy, whether to go for rotablation. I was afraid a little bit from no reflow, and I took a 1.5 balloon. It didn't cross. I took 1.2 balloon, and it did cross. And you can appreciate there is still, even with the small amount of the small size balloon, there is indentation in the upper. There is a nodule of calcium here. So the 1.5 finally crossed after several pre-dilatation of 1.2, but still you can appreciate that even the 1.5 is showing indentation on the above segment. There is a heavy calcium here. So what to do next? Rotablation, I didn't want to go with rotablation in this special case, but I took a body wire, and I took a body wire, the 1.5 balloon, once again, inflated. Then I took the 1.2 over the 1.5 because the 2.25 balloon couldn't cross. And I took the anchoring balloon 1.2, and I did simultaneous inflation with the 2.25 at a very low pressure, going gradually, very gradually, while keeping the 1.2 balloon inflated also at 10 atmosphere. And then the calcium yielded, and this was continuous screening. And then I took the non-compliant 2.75 so as to be sure that the stent will expand, and it did work in the same maneuver, taking it in high pressure with low pressure in the 1.2. And this is after stenting, and to introduce the NC balloon, the 3.5 balloon, I needed the body wire once again to cross. But this was the final result, and this was, I think, satisfactory and the good solution in this lady. So this was the final result. Our last case, which is a male patient, he's a younger age, he's 51 years, presented with inferior myocardial infarction, and the risk factor was hypertension and smoker. His clinical data was ongoing chest pain, despite that his presentation day after 24 hours. I'm sorry, I have to charge my computer. Sorry for that. Okay. So his ECG, I will mention it later on, the ECG. The echo showed inferior severe hypokinesia with ejection fraction 48, and the past history is irrelevant. Here is the ECG. It's clear that it's inferior MI, and there is Q wave in the inferior leads, lead 3, and AVF, and T wave depression also. The anterior showed nothing, and good progression. Here is his coronary angio that showed intermediate ostial lesion, the LED, and the LED then is totally occluded. Actually, it's occluded with minor bridging collaterals, as you can appreciate from here. The diagonal also. So it's an occluded LED, and the collaterals are not filling the right coronary except till the bifurcation. There is intermediate lesion of the ostial LED, then the occlusion, and then the right coronary full of thrombus. And this case has been done in 12 a.m. After midnight. And then the question, which way to go first, left or right, and which antithrombotic? Let's answer the second question first. The patient has been loaded 600 milligram of clopidogrel outside the hospital, and when he arrived in the emergency room, according to the guidelines, it's recommended that early after hospital admission, ticagrelor should be given in a loading dose of 180 milligram, irrespective of timing and loading dose of clopidogrel, and this what had been done to these patients. This is the scheme how to shift between the three ticagrelor, clopidogrel, and prasugrel. And why we shifted and reloaded, because to have this result, to have relative risk reduction in the primary endpoints of cardiovascular death, myocardial infarction, or stroke, and this could be achieved early. You can see that the two curves diverge early after randomization. With less bleeding, it's the same. It's the same bleeding. It's safe to give. Actually, I did go to the left first, and this was against the guidelines. The manipulator at that time, he told me, "Hey, guy, this is inferior MI. What are you doing?" But I was afraid a little bit to go. I said I must go to despite that the LED maybe it's chronic CTO, but it's short segment. I used the pilot 50. It couldn't cross pilot 150. It crossed also both. Crossed to the diagonal, but I seized the chance and took a 1.5 balloon, and I had to inflate the balloon, and then I managed to rapidly go to the lab and stenting and have this final result. And to tell you the truth, the patient's chest pain subsided after this procedure. And then the same technician had told me, "The OCLAD, are you going to leave it?" And I told him, "Hey, remember that we are in inferior MI, as you told me before." So I left it and I went right. And when I went right, it was difficult, but the pilot of aspiration, this was the result. That's why I took the decision to go to the left first. And then what to do? I had to aspirate again and again. It's inferior MI. And astonishingly enough, that the pain recurred after 45 minutes of working in the right, the pain has recurred once again. And the patient started to have chest pain. And I discovered that there is still occlusion distal, and I had to balloon and go with ballooning. And then now I'll show you this because this is important. I'm sorry. I return. Yes. Okay. Here is after aspiration. I used to inject from the aspiration balloon to see what's going distal, because a heavy burden thrombus is obstructing all this segment proximally, and I can see the flow. So I kept on with the ballooning once again, getting to bigger balloon, 3, then 3.5, then taking the 4 balloon in the here, 3.75. I'm sorry, and this was we got a flow, and the patients still have chest pain. I had to make this angio again, ugly, very ugly lesion, and whether to stent or not. Of course, I was not encouraged to stent in a very large thrombus burden, and I decided to accept this result despite the chest pain of the patient. But I was courageous enough. I moved to the left to see if there is anything in the stent because of the chest pain, but I found it excellent. So after 4 weeks, I decided to go into antithrombotic, and after 48 hours in the CCU, the patient's chest pain subsided completely. But I waited for 4 weeks, and then I re-angiod him, the same LED in the proximal ostial lesion. Maybe it's better a little bit in other views. Here it's better, and here is better also. The stent is okay, and the diagonal is okay. And then after giving this maneuver, ticagrelor 180 milligram, aspirin 100 milligram, and rivaroxaban 2.5 times 2 for 4 weeks, this was the result of the right coronary. We have TIMI3 flow, and let's go and revise ourselves. Are we following the guidelines here or not? Let's review. Triple therapy with aspirin, clopidogrel, and oral anticoagulant for longer than 1 month and up to 6 months should be considered in patients with high ischemic risk as our patient due to acute coronary syndrome or other anatomical procedure characteristic which outweigh the bleeding risk. When NOAC is used in combination with aspirin or clopidogrel, the lowest approved dose effective for stroke prevention, and this is in patients with atrial fibrillation. And for rivaroxaban, for example, 15 milligram is better than 20. The use of ticagrelor or prasugrel is not recommended as part of triple antithrombotic therapy. The and I didn't follow this advice in this case. I'm not encouraging the other fellow to do that, but I'm telling you that this was the result with the combination of the 3 drugs after 4 weeks. And I think Dr. Sobhi has passed and tell me go and stent, but I didn't want to stent. And this was his LV function after 4 weeks. And we decided to go after 3 months and get him back to see. But actually, because of the coronavirus, this had been done in November last year, and the patient is working abroad. He traveled January, and he's talking to me by phone. He's quite well, and he's doing light sport. And he asked me after 6 months, what to stop, the rivaroxaban, the ticagrelor, the aspirin, and I advised him orally till he can come and have his coronary angio. He didn't want to have it abroad, to just take 2.5 rivaroxaban, 1 tablet till he has his coronary angio. Which statin to give to all these patients with a high risk? The LUNAR trial has randomized rosuvastatin 20 milligram, rosuvastatin 40 milligram, and atorvastatin 80 milligram. And rosuvastatin 40 milligram has the lowest LDL level after 6 to 12 weeks from randomization. So we are encouraged to give this dose to our high-risk patients. So my final thought that calcified lesions are still posing some difficulties to face during PCI procedure. Thrombus-containing lesion in acute coronary syndrome plus calcium add more difficulties that may need more than a way to handle. Rotational atherectomy may lead to neural flow. Remember, in some cases, 2-balloon technique was an option in the case number 3, and it did work in this elderly patient. Multivessel disease in elderly presenting with very high risk non-STEMI needs special handling and balance between complete revascularization in the same setting or deferred complete. Aspiration plus balloon, then long-term antithrombotics may be a good solution in some cases of STEMI. And points to remember that DAPT using ticagrelor 60 milligram is the only agent recommended if you're going to extend beyond 1 year from the guidelines. And for acute coronary syndrome patients, switching from clopidogrel to ticagrelor 180 milligram recommended early after hospitalization, irrespective of the loading dose of clopidogrel. And from the other part of the Mediterranean, me and Dr. Sobhi from the RORS course are sending the best regards to our French colleagues on the other side. Thank you.
Thank you, Amra, for this very interesting and provocative cases for acute coronary syndrome with calcification, thrombosis. I think we have a lot of questions about these cases. I will start giving you one question. You said that when I remember this patient. Yes, you are right, because sometimes the question for the ectatic vessel to do it or not, this is a question. You give this patient antithrombotics, and then on the re-angiogram, there is nothing to do that. So congratulations for this case. But I disagree about to do the LED before the right coronary. This is, I think we have to discuss this because sometimes if you have a difficulty in LED, or have you going to lose your patients.
Yeah.
Ticagrelor can be extended up to 36 months in most of your patients. Ticagrelor.
Yes.
Okay.
Yes. But 60 milligram.
Yeah. And regarding your assumption of rivaroxaban, I think Jill Montelesco can the last wave he speak about when to give rivaroxaban as the third drug, or the Compass trial for those patients. For this kind, it's only I think 2.5 twice. It's not only 1. Jill, can you assist us for this with Amr? The rule of antithrombotics for following for continuation, the duration of DAPT for ticagrelor, how 36 months or not, and then the rule of rivaroxaban in multivessel disease and calcified lesions?
Yes, it was a very interesting case. Thank you for this beautiful presentation. And the last case, yes, you have several questions, which is one, what is best treatment acutely when the patient leaves the cath lab? And for these ectatic vessels, clearly anticoagulation is a way to go in addition to antiplatelet therapy. My take on rivaroxaban 2.5 during the acute phase, it's a low level of anticoagulation. I would have preferred probably a full dose of low molecular weight heparin during the hospital phase and transition afterwards at the time of discharge to rivaroxaban 2.5. And then comes the question for the long-term treatment. And you have several options, of course, and one is a compass strategy, 2.5 milligram BID plus aspirin, or to use aspirin and ticagrelor, 60 milligrams like Pegasus. We don't have head-to-head comparisons between these two strategies. I think both are fine. My take on this is that when you are more worried by the coronaries and the stent, I think the Pegasus strategy is fine. 60 milligrams and aspirin, it's probably the right way to go. But if you are worried about the clinical profile of the patient because you have organ failure, because you have a high ischemic risk in general, and in this case, especially in patients with PAD, for example, I think rivaroxaban plus aspirin is preferable. The two strategies are, we need to say that the two strategies are applicable only if you are dealing with a low bleeding risk patient.
Yeah,
to answer,
okay, Mohammed. You can
because yes, the patient was on heparin till day 5. When he left the hospital, I prescribed the rivaroxaban 2.5 twice a day beside the ticagrelor, which against the guidelines a little bit, but I didn't want to shift him once again to the clopidogrel. I said, this is a heavy burden thrombus, keep on ticagrelor with this low rivaroxaban dose.
And Antoine Lafont with us?
Yes, thank you very much, for this beautiful presentation. In fact, you managed the fact that we have to go around the guidelines, but I agree with Mohammed for the last case regarding the fact that you took the chronic artery closed to be treated in emergency instead of the right coronary artery. I've not really understood the rationale.
Why?
And my second question regarding this point is also why did you not use GB2B3 inhibitors in this case? Because what we see in this right coronary artery, which is totally ugly, that you have reoccurrence of the thrombus at the first and the second level, and despite the flow was clearly well reestablished, it was not sufficient to fight against this hurricane of thrombosis.
Okay. It's a good question, but I talked so rapidly because of the presentation. Actually, the patient came from the cath lab on one day on G2B3A plus heparin, half dose, plus ticagrelor, plus aspirin. Then heparin was continued. Then before discharge, beside heparin in day 4, rivaroxaban 2.5 twice. So we loaded him with the anticoagulants. Regarding why did I go left rather than go right, I anticipated actually great difficulties. And viewing the angiogram, there is collaterals from the left just to the bifurcation, to the PL and small PD. It's not going up. So I anticipated the very long occlusion or acute occlusion on top of proximal occlusion on top of chronic in the at the bifurcation, which was the case. That's why I got rapidly to the left, anticipating that I'm going to succeed. But this is, of course, it's out of the guidelines. And actually, this chest pain, astonishingly, has completely relieved after recanalizing the LED. But recurred once again when we loaded thrombus in the collaterals. So maybe this is out of the guidelines, but I anticipated great difficulty. I stayed in the right coronary for 1.5 hours, and they didn't give. Remember, if I didn't have the lead recanalized with this complication, maybe I have lost the patient during recanalization. But it's not rationale. I am saying this is exception in this case.
Oh, Terry.
I like very much your presentation because it illustrates the discussion that we have in daily practice. And in many cases, we are in front of the guidelines. So we anticipate the guidelines and we are not following the guidelines for this reason in all cases. I just want to add a discussion about complete revascularization because we have opposed complete revascularization to incomplete revascularization, but in fact we have full complete during the same session, or full complete during the same hospital stay, or full complete within the next 1 or 2 months. Okay. And it's different. And in the other way, you have full incomplete. So you do you reopen the culprit lesion, and then you leave the patient like that. You don't do any test, etc. So I think between all these different complete and incomplete, there is a good way to find the optimal decision for each patient. Yeah. So again, it's a discussion that we need to have. I think we should not do a complete revascularization. For example, the case that you have done with the LED on the right. I think it's not a case for young interventionalists. It's a case for very experienced interventionalists, and you are. But for other people, I think it could be very difficult to do this kind of case, or maybe dangerous. So I think it depends on many parameters, experience of the operator, the discussion that you can have during the case, and during the night you cannot have discussion. So all these things are very important, but I think doing complete acutely in all cases, it's a mistake. Yeah. But doing incomplete is also a mistake. So all the patients are different. And again, we should discuss for each patient what is the best strategy for the patient.
Totally agree. Yeah.
So do you believe in residual syntax score? I mean, if you less than 8 or more than 8, you can make it as a form of discussion.
Okay. Absolutely, I think it's a very good point. Yeah. And especially when you do a left main disease, for example. So when you take a decision for multivessel disease, you have to make this calculation. Which kind of residual syntax score I will have at the end of the procedure, as compared to what will do the surgeon. And it helps you to take the good decision for the patient.
Okay. Any questions? I don't have more questions. Thank you very much, all of you, for this coronary sessions. Then we shift to the heart failure session. Joining with us, Dr. Mustafa Nawar. Can you open, Mustafa, your camera and mic? And we have Dr. Haggi with us as well. Dr. Amr Zaki.
It's my pleasure now to introduce. Hello, Dr. Mustafa.
Hello.
Okay, it's for the second session. It's my pleasure to introduce my colleague and my boss, Dr. Sobhi, is going to talk to us about the dilemma of SGL2 inhibitor in heart failure, with or without diabetes.
Thank you, Amr. After this important topics on coronary session, we shift to the heart failure session. I think we choose the heart failure because nowadays it's a very important in our life, and we have a lot of webinars, we have a lot of trials. So I think although we are intervention cardiologists, that we have to treat the heart failure. So my talk today is about the dilemma of heart failure, the real patient profile and practical recommendation. I'll choose 2 patients for you. This is the real patient profile. Mr. Amin is a male, 65 years old, businessman, ex-smoker, diabetic, obese, hypertensive, dyslipidemic, anemic, hypothyroid, CKD, with albuminuria, dilated cardiomyopathy, ejection fraction 39, atrial fibrillation, CRT done in USA, shortness of breath, palpitation, mild exertion, swollen lower limbs. He's 122 kilograms, he's obese, pulse 70, irregular because of atrial fibrillation. Hypertensive, 180, 110, raised GVP, enlarged liver, bilateral renal edema, and pitting edema. His lab is more or less not anemic, 10.8, ESR is 45, CPR is 12.8, random blood sugar 260, hemoglobin is 1C is 7.6, creatinine 1.5, eGFR is 50, uric acid 6, albuminuria 665, TSH 5.8, SGAT 20, albumin 3.8, calcium 8.4, magnesium 1.9, sodium 138, potassium is normal cholesterol, triglycerides, HDL, and normal LDL. So what's his problem? The current medication is doing well, more or less, atorvastatin 20, climapride 2 milligrams twice daily, metformin once, apixaban twice, 5, torzimides 20, epinephrine, carvedilol twice, losartan 100, pantazole 40 milligrams. So what is this patient now? In spite of all these optimal guided treatments, is symptomatic, have heart failure with reduced ejection fraction, it's called HFrEF. So Mr. Amin, major concern with the worsening heart failure symptoms, CKD progression, optimization of diabetic type 2 diabetes, obesity, blood pressure, lipids, all of the above. I think all of the above. So what to do for this patient? Because now we are in the treatment of heart failure, but in this phase of refractory heart failure. What are the guidelines? Yes, we took this patient was taking diuretics, ACE, beta blockers, mineralocorticoids, still symptomatic, ejection fraction literature. So we have three options: either to use ivabradine if the heart rate is, but this is patient atrial fibrillation, sinus rhythm, so evaluate the need of CRT, or to change to ARNI to is. So we have two missing now. So in all these drugs is improvement of symptoms: ACE, ARBs, beta blockers, diuretics, aldosterone, improve survival in most of these drugs except the diuretics. The use of guideline recommended therapies was associated with the survival benefit in the improvement. Let's say the dose. For my patients, I think we have optimization of them. So what's next? You have a trial which favor another drug or drugs. As you can see, started the treatment, the heart failure trials from 1986 with the consensus. I remember this, and then Valhept with the ACE, then IRBs, mineralocorticoids, and then finally we have two trials, which is called Paradigm and DAP. Our current medication of the Mr. Amin, this is what we have. So how can you optimize? Replace, number one, either to replace the ARB with ARNI, or number two, initiate SGLT1 as per DAPA heart failure, or three, replace ARB with ARNI and DAPA. Do you have evidence? Actually, we have evidence for ARNI with the Paradigm. So regarding SGLT2, which are our concern today, how can we better improve the outcome in HFrEF patients, when, where, and how to initiate SGLT2? Do you have evidence? We have evidence, the wealth of evidence. We have health regarding the quality of life and safety measures. We have practice. We have guidelines for the future. Let's speak about the wealth of evidence. The difference between study cohorts. This is number one study, EMPA outcome. This is 100 secondary prevention. The Canvas program, 34% primary prevention, 62% secondary prevention. In Declare TIMI 58, 60% primary prevention, 40% secondary prevention. So this is in coronary artery disease, cardiovascular disease, and PED. Regarding the trial, these three trials, the history of heart failure was about in 10% of EMPA, 14% of Canvas, and only 10% of legal. So a small, less than 15% of GL2 cardiovascular outcome study, but there is a history of heart failure with a small number. So for the first trial, which is the EMPA-REG, it's 14% reduction in the primary outcome in MACE. And regarding the hospitalizations, cardiovascular deaths, outcome vary between 35 to 39. The Canvas is 14% primary outcome. The Declare TIMI 58 is only 7%, but actually with dual primary outcome in cardiovascular deaths and history of hospitalization, recurrent hospitalization, between 17% and 7%. So we have dual primary outcome. The declared TME58, there is also composite of eGFR decreased by more than 40%, as you can see by relative risk reduction by 47% if you compare the placebo with dapagliflozin, which is 10 milligram, 1.5%. The credescence, which is for the key renal and cardiovascular outcome, the primary outcome is great. It's 30% relative reduction in type 2 diabetes with albuminuria and CKD and efficacy. So we have established cardiovascular benefits regarding diabetes proteinuric CKD in credence trial. In diabetes, we established atherosclerotic disease in 3 trials. In diabetes with cardiovascular risk factors in 2 trials. But the benefits unknown in diabetes with no other cardiovascular, and also in patients with or without diabetes established heart failure. We have evidence. This evidence was pending. But DAPA heart failure was announced in European Society of Cardiology 2019. What are the results of this? This is 4,744 patients with heart failure reduced ejection fraction less than 40%, taking dapagliflozin versus placebo. What the results? The results was in the primary composite outcome, CV deaths, heart failure hospitalization, urgent heart failure visits is 26%. In both cardiovascular and or hospitalizations, only 25%. In cardiovascular deaths, 31%. All-cause deaths is actually 17%. So if you collect this, it's more than 5,000, up to 5,000. But these patients, 45% diabetes, 55% without diabetes. So with 10 milligram DAPA versus placebo, these are the results, and this drug was well tolerated with no access to excessive side effects. Then they compare for DAPA heart failure, diabetic versus not diabetic, there is no difference. Educated acute kidney injury, it's wide difference with, as you can see, with Hazard ratio 0.65. The real composite outcome is the Hazard ratio is 0.71. There is no difference in all treatment subgroups with other drugs, and starting this at the timing of 28 days if you collect the effect in the first 100 days. So what about the constant result across all subgroup analysis? Actually, the constant benefits regarding the age, gender, body mass index, systolic blood pressure, diuretic therapy, heart failure etiology, pro-BNP, heart failure therapy, or left ventricular ejection fraction. When you compare the two drugs nowadays, the paradigm heart failure using ARNI versus enalapril, and DAPA heart failure, this is 8,000 patients. DAPA heart failure is about 5,000 patients, placebo versus DAPA. What we can see, the background therapy is the same. The cardiovascular death hospitalizations on favor of it's more with DAPA, but it's more or less the same. Heart failure hospitalizations less in paradigm than DAPA heart failure, and cardiovascular death is the same. So if you compare the two complementary therapies with distinct additive mechanism of action versus placebo, as you can see in the blue here diagram, can see this is in favor of the combined, in favor that you can use these two drugs in spite of giving each one of them. About the health, the quality of life, this is a study of the clinical summary score showing the improvement on quality of life. We like what's known as improvement quality of life in paradigm heart failure trial. Do you have any side effects of volume depletion? Something, nothing of the serious effects. Regarding the practice, the guidelines of the future, the DAPA heart failure is a momentum victory in the war against heart failure. This by Deepak Bhatt, as you can see with Verma and also the Brunwald published in the Cell Metabolism Previews. So SGLT2 is a new pillar of heart failure reduced ejection fraction. I think yes, with this is the famous pillars, and this is the fifth pillar with the DAPA. So in this published in the position paper in the European Journal of Heart Failure just in July, the 2nd of July 2020, sodium glucose co-transporter 2 inhibitors in heart failure beyond glycemic control. This is the position statement. The second patient. These patients is monad Egyptian female, 74-year, obese, with type 2 diabetes, long-standing hypertension, SNIHA 3 with obstructive sleep apnea, the ankle edema, no prior myocardial infarction, nuclear study risk normal EKG, no ischemia, just LVH, normal ejection fraction, right ventricular systolic pressure is 48, just for post-protocol 1.5 minutes because of shortness of breath. It's not blood pressure rise within 1.5 minutes from 140 to 80 up to 190, 100. The ProMP is 700, globulin 1C 73, AGFR is 76, potassium is normal. So this case is heart failure, but with HFpEF. It's heart failure with preserved ejection fraction. And this patient is taking metformin, liraglutide, ramipril, Lasix as well. So Mona is taking these drugs. How optimized is heart failure with preserved ejection fraction? Options are limited for treatments. Do you have any trial for this? We can see. Can you consider adding mineralocorticoids, which have top cats? Can you consider adding SGL2 for cardiorenal protection? Or we can wait for the liver and preserve it prior to initiating SGL2 for treatment of heart failure preserved ejection fraction. These are the famous 4 trials for HFpEF. PEP, congestive heart failure with perindopril, is non-significant. CHARM preserved candesartan, non-significant. The eye preserved irbesartan, non-significant. And top cats, spironolactone, more or less, but it's less significant. Then come the Paragon heart failure primary results with ARNI, actually, versus valsartan, 2,300 and 2,400. As you can see, there is no difference except in 2 situations, in the mid-range heart failure and also in women. The heart failure hospitalization, cardiovascular death, there is no significant difference. But there's 2 ongoing trials of the SGL2. One is called DELIVER, and the second called Emperor Preserved, for studies of heart failure preserved ejection fraction. How this drug SGL2 can act? Can look to the 2 or 3 coming slides. It's causes glycosuria. It's called glycemic effect. It decreases hemoglobin A1C, decrease glucotoxicity by increasing insulin resistance, blood beta cell function, decrease body weight. And also natriuretic increase osmotic diuresis by decreasing blood volume, decreasing blood pressure, decrease glomerular hyperfiltration, decrease interstitial fluids. So we have glycemic effect and extra glycemic effect. This effect on heart failure is through 3 mechanisms. One is reduction of the preload and afterload, by decreasing vascular resistance and plasma volume, improve myocardial energetics by reliance on fatty acids, cardiac norepinephrine, decrease ketone body formations, and cardiac remodeling by decreasing cardiac wall stress and decreased inflammation. This will result in clinical effects: blood pressure reduction, improved cardiac contractility through increasing diastolic function and decreasing left ventricular mass. Actually, for this heart failure with preserved ejection fraction, after these 4 trials and the Paragon trials here, in the 2 ongoing trials is DELIVER and Emperor. The third mechanism of the renal outcome, that SGL2 inhibition reduce glomerular filtration pressure, neurohumoral improvement, inflammation, fibrosis, decrease renal workloads, so preserving renal function. What about the pathophysiologic interaction between the kidney, type 2 diabetes, circulation, the heart? Actually, for the heart, we said that decreasing the preload, afterload, and wall stress, improvement of the circulation, and improvement of cardiorenal, decreasing cardiorenal complication. This SGL2 inhibition will lead to glycosuria, diuresis, natriuresis, and finally, we have improvement of heart failure, and we have improvement of cardiorenal protection. So this is my last slide. From prevention to treatment, from diabetes to everyone. We are in the era of SGL2 inhibitors for the cardiologists and diabetologists. For heart failure, proved now with heart failure reduced ejection fraction, for DAPA, for DEFIANT, for Emperor, And for type 2 diabetes and type 2 diabetes CKD and CKD as well. And together we are waiting for heart failure with preserved ejection fraction. My summary and conclusion: DAPA heart failure is the first heart failure outcome trial with SGLT2 investigating treatment of heart failure in adults with heart failure reduced ejection fraction on top of the school guideline treatments, standard care individual with or without diabetes. This is very important, with or without diabetes. The second conclusion, that DAPA provided a statistically significant and clean reduction in the risk of worsening heart failure events and cardiovascular death when compared to placebo, as well as improvement heart failure when added standard therapy. The third conclusion, safety finding consistent along all the safety profile with the rate of discontinuation low. SGLT2 inhibitor present a new cornerstone in heart failure reduced ejection fraction and widespread future maybe in the heart failure with preserved ejection fraction and CKD patients as well. And thank you very much. I'm waiting most of you and all of you in 5 to 9 of October, because cardio Alex doesn't cancel, just postpone to the 5 to 9 of October. And thank you very much, my colleagues.
Thank you, Dr. Sobhi, for this nice talk, and we'll raise for the discussion questions from Dr. Mustafa Nawar.
Yes, I don't. Oh, thank you.
So, any question? I'll ask you one question.
Thank you, Professor Sobhi. It's a very nice and very didactic presentation, complete. Sample practical question: can you use SGPTL2 in patients without diabetes?
Yes, according to the DAPA, heart failure is only 54% in patients. 54% is non-diabetic, and 5% is diabetic. So according to this, it's be allowed to us to can use it in as adding to ARNI, but you have to start ARNI because already in the guidelines. And when the European staying on top, the American said you can give it from the beginning. But SGLT2 now, because of DAPA heart failure, I think this is I said in one of my slides, if this is complementary to the ARNI as well. So we can use it in heart failure patient, but not from the start.
Okay.
You can ask the French, the French group, Antoine, are you using SGLT2 in your country for heart failure patients?
Well, you know, dapagliflozin had just been approved in France. We were a bit delayed, and I think it's going to be used a lot. We would get the EMPEROR study presented at ESC, as you know. And it's very important because, as you said, we don't have much data in patients with heart failure and preserved ejection fraction. And, you know, from what we have in subgroup analysis, there is a suggestion that it will work also. So it's very good news because we don't have much good treatment for these patients. And clearly, you know, when you have to choose between increasing the blockade of the renin-angiotensin system or to use dapagliflozin, for example, in these heart failure patients, my impression is that there is one drug which is better tolerated than the other, and dapagliflozin is a very good candidate because in terms of blood pressure, it's very well tolerated by the patients. So I think we will use this drug more and more in heart failure patients, and possibly whatever the ejection fraction.
Okay, Antoine.
I agree with Gilles. We don't have a lot of experience of this drug because we have access. And it's nice to have a new drug in this type of patient where, in fact, the outcome is really not controllable. Can you tell us what are the contraindications of this drug?
Actually, if there's hypotension also as well, you know, because they decrease the blood pressure. That's only regarding the hypoglycemia patients, which also the contraindication to these patients. But otherwise, there is no
renal dysfunction is an issue also. Renal dysfunction.
renal dysfunction. Yeah.
It's also
Urinary tract infection, yeah. Severe urinary tract infection or genital infection. Dr. Sobhi, for patients with heart failure and preserved ejection fraction, most of the trials are negative because I think hard endpoints, it will almost be negative. You need the quality of life in these patients because mortality, I think they haven't got increased mortality, or what do you think about that? It's the quality of life.
I agree completely because, I think we have a lot of webinars with the heart failure summits groups with Spitter, with Stephen Anker, with the Severik as well. They said that symptomatic treatment is important for the patients, but they will not reach the conclusion. But I think the ARNI is promising because in special population, and they're going to reclassify the ejection fraction. I think it is the mid-range, particularly. Why it's important in women? Because I think the ejection fraction in women is different from men. So that's why it's important to be used in women, this kind of drug, which is the ARNI treatment. Regarding the quality of life, actually we don't have a reliable part of treatment because you are depending on ejection fraction. I think the ejection fraction is not the cornerstone for the heart failure. Maybe something like the cardiac MRI, the longitudinal strain, or something which is missing to us to understand the benefits of the drugs. So I think we can manage these patients, whatever which is preserved or not, by the same drugs, because we don't have a specific drugs. But I think mineralocorticoids may be effective, maybe as a top cat, adding to ARNI in these situations. And I hope, as Jill said, maybe in the future, SGL2 is the drug of choice of preserved. Is there Lefebvre with us?
Yeah. Yes, I am with you. I was very impressed by your presentation. I think these data are very strong. And unfortunately, I have no experience in my hospital with this drug. It was just launched a few weeks before. So, but it's very promising.
Okay. I think thank you very much for this, and come to the last. Dr. Mustafa, can you introduce the Dr. Hagi?
Yes. First, I would like to thank Professor Lefebvre, Professor Lafont, Professor Montelescu, and my colleagues, Professor Sobhi and Professor Zaki, for their presentations. They were very interesting. And I would like to introduce my colleague from Tunisia, Professor Haji Abdeldaim. He's a cardiologist in Tunis Military Hospital, and he's the head of Rhythmology and Cardiac Stimulation Unit Professor of Cardiology at the Faculty of Medicine of Tunis, El Manar. He's a member of the board of the Cardiology College of Cardiovascular Surgery and Vascular Surgery of Tunisia, principal investigator in clinical studies in the field of sudden cardiac death prevention and improve sudden cardiac arrhythmia bridge, STCA. I'm also contributing in these studies with Professor Haji, and it's nice to hear from him about the updated on sudden cardiac arrest and heart failure. Professor Haji, please.
Thank you, Professor Nawar. It's good evening, everyone, dear colleagues and fans. It's an honor and pleasure to participate in this webinar, which deals with cutting edge and topical subjects. I want to thank Medtronic. I want to thank to Professor Sobhi for giving me this opportunity to participate. Without too much delay, I will go to the heart of the matter. Chronic heart failure is one of the world's leading epidemics. As in the Framingham study, total mortality was 24% in women and 50% for men during the 4 years of symptomatic heart failure development. Contemporary pharmacology therapies, beta blocker, ACE, AIR2, ivabradine, anti-aldosterone, have been implemented substantial reduction in heart failure mortality. Despite these advances in medical treatment, heart failure is still carrying heavy morbidity and mortality. The management of heart failure goes through several phases classified into several stages from A to D. The management stage B, the management of asymptomatic LV dysfunction involving the prescription of ACE inhibitor, angiotensin II receptor antagonist, and beta blockers. In stage C, the management of symptomatic heart failure, in addition to basic treatment, requires with diuretics and non-pharmacologic treatment of heart failure, such as cardiac resynchronization treatment or mitral insufficiency by MitraClip, myocardial revascularization by angioplasty, or by coronary artery bypass. Stage D is the terminal stage of heart failure, and the management becomes quite heavy and involves circulatory assistance, heart transplantation, inotropes, but also simple palliative care. In 2016, the European Society of Cardiology published a new recommendation on the management of chronic and acute heart failure. We find in this a nice algorithm which summarizes the steps of the management of chronic heart failure with the inclusion of pharmacological treatment and non-pharmacologic intervention. A year later, the American Heart Association, American College of Cardiology, and Heart Rhythm Society published the recommendation on the prevention of sudden death and ventricular arrhythmia. Sudden cardiac death constitute major public health problems, accounting for approximately 50% of all cardiovascular deaths, with at least 50% being first symptomatic cardiac events. The incidence of sudden death remains high and varies from country to country. It's more common in developed countries compared to the African continent and Asia. The proportion of cardiac arrest increases according to the population group at risk, such as patients with congestive heart failure with ejection fraction less than 35%. The proportion, but what such cardiac death is a sudden, unexpected death caused by a change in the heart rhythm. It's the largest cause of natural death in the Western countries, responsible for half of heart disease deaths. Coronary artery disease is the most cause of sudden cardiac death, accounting for up to 80% of all causes. The definition of sudden death cannot be applied literally to patients with heart failure because they have ongoing symptoms and established cardiovascular disorder. So the term unexpectedness may be more appropriate. Recently, Milton Packer published an update to explain the pathophysiology of sudden death and possible intervention to reduce the risk of its occurrence. Of this algorithm, we can identify two mechanisms of sudden death, rhythmic and non-rhythmic, for the prevention of sudden death. From cardiac arrhythmia, there are two levels of intervention: and direct prevention by the treatment of myocardial ischemia, by the equilibration of the fluid and electrolyte balance, and by the reduction of adrenergic discharge. The second direct level is the prevention and treatment of ventricular arrhythmia by antiarrhythmics and by the implantable automatic defibrillator. Sudden non-arrhythmic death occurs via negative reverse remodeling, which will result in myocardial breakdown and the occurrence of electromechanical dissociation or asystole. Pharmacological treatment and cardiac resynchronization could slow down or even create a positive reverse remodeling. For heart failure patients, there are many aspects of their condition that physicians attempt to manage, and there are many medical therapies in our arsenal to assist patients. However, only electrical therapy like CRT can address underlying electrical dysynchrony for patients at risk of sudden cardiac death, while some medical therapies have an effect. None are effective as defibrillation therapies, whether is an automatic external defibrillation or wearable, such as a vest or an implantable device. Now we will go to some medication. For example, beta blockers. In this meta-analysis published on 2013, the authors showed that beta blockers reduce the risk of sudden cardiac death by 31%, cardiovascular death by 29%, and all-cause mortality by 33%. These results confirm the mortality benefit of these drugs, and they should be recommended to all patients, similar to those included in the trials. For another beta blocker, but this is an antiarrhythmic, sotalol, among patients evaluated, administration of D-sotalol was associated with increased mortality, which was presumed primarily to be due to arrhythmia. The prophylactic use of a specific potassium channel blocker does not reduce mortality and may be associated with increased mortality in high-risk patients after myocardial infarction. For mineralocorticoid receptor antagonists, in this meta-analysis, including the most important trials, RALES, EPHESUS, and EMPHASIS heart failure, mineralocorticoid receptor antagonist versus placebo, the authors showed that mineralocorticoid receptor antagonists compared to placebo reduced the risk for sudden cardiac death by 23% in patients with heart failure and left ventricular dysfunction. Neprilysin inhibitors. The paradigm heart failure investigators compared the angiotensin receptor neprilysin inhibitor with enalapril in patients who had heart failure with a reduced ejection fraction. In this trial, patients with ischemic dilated cardiomyopathy represents about 60%. They found that LCZ 69296 was superior to enalapril in reducing the risks of death and hospitalization for heart failure. For ivabradine, SHIFT assessed the effect of heart rate reduction by the selective sinus node inhibitor ivabradine on outcomes heart failure. The primary endpoint was the composite of cardiovascular death or hospital admission for worsening heart failure. In this study, there were a benefit on reduction of rehospitalization, but not on cardiac death, cardiovascular death. Other medication prescribed for patients with ischemic heart disease, for example, statins. In this clinical trial published by Corona Grab, rosuvastatin 10 mg per day compared to placebo did not reduce the primary outcome of the number of deaths from any cause in older patients with systolic heart failure. Although the drug did reduce the number of cardiovascular hospitalization, the drug did not cause safety problems. The effect of rosuvastatin in patients with chronic heart failure was studied in the GC heart failure trial, randomized double-blind placebo-controlled trial. Rosuvastatin 10 mg daily did not affect clinical outcomes, death and hospitalization in patients with chronic heart failure of any cause in whom drug was safe. In this trial, 40% of patients enrolled had ischemic heart disease as primary cause of heart failure. Did anticoagulant reduce sudden death in heart failure, reduce the ejection fraction on sinus rhythm, and with coronary artery disease? For this question, Commander heart failure investigators hypothesized that treatment with rivaroxaban at a dose of 2.5 mg twice daily could reduce thrombin generation and improve outcomes for patients with worsening heart failure and underlying coronary artery disease and no atrial fibrillation. The study was negative, and rivaroxaban was not associated with significantly lower rate of death, myocardial infarction, or stroke than placebo. Treating comorbidities is very important for heart failure patients. Commonly have multiple comorbid diseases that complicate management. Risk factors such as smoking, obesity, and advanced age increase the burden of non-cardiovascular comorbidities, including chronic obstructive pulmonary disease, sleep apnea, and diabetes mellitus. Approximately 40% of patients with acute heart failure have diabetes, were diabetics. Diabetes is prevalent in both heart failure, reduced ejection fraction, and preserved ejection fraction. Similar increased risk for mortality in both groups. An intensive glucose control strategy can effectively reduce the risk of major cardiovascular events, but at the expense of a significantly increased risk of severe hypoglycemia in patients with type 2 diabetes. This is a reduction of MACE and myocardial infarction, but not death, cardiovascular death, stroke, or heart failure. And now, Professor Subhi showed the effect of new antidiabetics, SGPHL22. Now we will shift to cardiac resynchronization therapy. Cardiac resynchronization is an appropriate treatment for heart failure when the left ventricular ejection fraction is low and in the presence of an electric asynchronism. This is the last therapeutic chance per device before the indication of LV assistance or heart transplant. CRT improves stress tolerance and class NIHA, induces reverse remodeling, and reduces mortality and hospitalization. This is the benefits of resynchronization, which have showed by several large clinical studies. For example, in companion study, investigators showed that the patient with advanced heart failure and a prolonged PRS interval, cardiac resynchronization therapy decreases the combined risk of death from any cause of first hospitalization, and when combined with an implantable defibrillator, significantly reduces mortality. In this study, the proportion of ischemic dilated cardiomyopathy was about 55%, and the patients receiving CRTP was equal to patients receiving CRTD. These clinical studies have clarified the indication of defibrillators in the prevention of sudden death, whether in primary prevention or secondary prevention. ICD therapy recommendation confirmed also by the European Heart Failure Association. Class 1. Just some critique for Danish. Danish trial published in 2016 created a lot of questions about ICD benefit. Shortly after this publication, several analyses and meta-analyses were done to understand this result better. Then they have confirmed ICD benefit. The study limitation was the sample size, the selection bias, no knowing how many patients were assessed for eligibility. The mean duration of heart failure was 1.5 years, and monitoring assumption. Are the guidelines still valid? They were based on studies published 15, 20 years ago. For example, this is a Swedish heart failure registry, was also presented last year. It has confirmed ICD benefit that was observed in all subgrad studies. Another very important trial, namely for emerging countries, is improve sudden cardiac arrest that was published recently. It's the biggest device trial done in emerging countries. In these studies, we have included 67 patients from our department. This study compared the three groups of patients, those in secondary prevention, those in primary prevention, and another intermediate group called 1.5. The group 1.5 classically part of primary prevention, but with additional markers such as syncope, low ejection fraction, less to 25%, a significant ventricular extrasystole with on rhythmic halter. This trial shows a dramatic reduction of the risk of mortality in patients with 1.5 criteria, 49% relative reduction in mortality risk with ICD in 1.5 patient group. In 2019, the Heart Failure Association consensus group didn't identify any new evidence to revise guidelines recommendation on ICD implant in patients with heart failure, reduction ejection fraction, and coronary artery disease. The consensus view was that one may consider not to implant ICD in patients with non-ischemic heart failure, reduction ejection fraction who are aged above 70 years or have advanced symptoms, NIHA 3, 4, or high, or have life-shortening comorbidity. For primary prevention, our current approach to sudden cardiac death risk stratification relies mainly on the evaluation of left ventricular ejection fraction values below 30-35%, allow the identification of ICD candidates who are at highest relative risk of sudden cardiac death. On the other hand, patients with a left ventricular ejection fraction above 35% account for the highest absolute number of sudden cardiac deaths. For this reason, many researchers emphasize that ejection fraction is an inadequate marker for detecting patients who are at high risk for sudden cardiac death despite having a normal or subnormal ejection fraction. For secondary prevention, sudden cardiac death risk is significantly higher and risk stratification is certainly more standardized. Patients with non-ischemic heart failure represent a broad and diverse group of patients, including those with progressive and infiltrative forms of cardiomyopathies. For this reason, the risk of developing VT in non-ischemic heart failure is difficult to accurately predict this group of patients. Current 2015 USC guidelines say that NECM patients with symptomatic heart failure, NIHA 2 or 3, and left ventricular ejection fraction less 35%, despite optimal medical treatment for above 3 months, are having class 1 indication for ICD implant. According to 2020 consensus, further risk stratification in non-ischemic cardiomyopathy patients who otherwise don't meet an indication may be considered. Now we will go to sudden cardiac death in heart failure, preserved ejection fraction. Is the most common single mode of death in heart failure preserved ejection fraction, constituting nearly 40% of cardiovascular deaths and 25% of all deaths. Sudden cardiac death could be a potential therapeutic target to reduce mortality. However, in contrast with heart failure reduced ejection fraction, there has been relatively little enthusiasm in testing intervention to reduce sudden cardiac death in heart failure preserved ejection fraction, largely because of a higher proportion of non-sudden or non-cardiovascular deaths. The patient's age, sex, male, history of diabetes mellitus, history of myocardial infarction, presence of left bundle branch block on the electrocardiogram, and the anti-proBNP level are predictors of the sudden cardiac death risk. The sudden cardiac death risk prediction model identifies a subset of patients with heart failure, preserved ejection fraction, who have a high risk of sudden cardiac death. The use of this risk prediction model as part of an entrance criterion makes a sudden cardiac death intervention trial in heart failure, preserved ejection fraction feasible. How we can predict sudden cardiac death following myocardial infarction? In this post-hoc analysis of the highest risk acute myocardial infarction database, authors developed an easy-to-use score for predicting the risk sudden cardiac death in patients with heart failure, left ventricular systolic dysfunction, or both, nearly after acute myocardial infarction, including 12 routinely collected clinical variables which were independent predictors of sudden cardiac death: older patients, heart rhythm, active smoking, Philip class, low ejection fraction, previous myocardial infarction, atrial fibrillation, history of heart failure, diabetes, kidney disease, and index perfusion. The score is superior to left ventricular ejection fraction. This score may be useful in identifying patients for future trials testing treatment aimed to reduce the risk of sudden cardiac death after acute myocardial infarction. The Improve Sudden Cardiac Arrest Bridge study is an ongoing study which will assess care pathway for post-acute myocardial infarction patients through standard assessment of left ventricular ejection fraction. The objectives of this study is to characterize the proportion of post-acute myocardial infarction patients who are referred for sudden cardiac death, risk stratification and management, characterize the proportion of post-acute myocardial infarction patients who receive an ICD or CRTD within 12 months post-acute myocardial infarction, and characterize the proportion of post-acute myocardial infarction patients who experienced cardiovascular mortality. There is approximately 5 sites, China, MIA, and in our center, we reached the number of inclusion that we set last month. To conclude, sudden death is an important mode of demise in patients with heart failure, reduced ejection fraction. Unaware of this risk, many practitioners often assume that clinically stable patients with mild to moderate symptoms do not require intensive therapy. As a result, intervention that can prevent sudden death in heart failure reduction ejection fraction are underutilized. Thank you for your attention.
Mustafa.
Thank you, Professor Haji, for this elegant presentation. And thank you also for the contribution in the sudden cardiac arrest trial in which you are contributing together with the Egyptian Center. I would like to ask you about if a patient with CRTD after during reimplantation after 8 to 9 years, if he had received no shocks, do you still replace a CRTD device, or you prefer to shift to CRTP for cost problems?
This is a good question. Depending on the comorbidities of patients, so if patients has a good condition without, for example, neoplasm or kidney disease, we still with CRTD. And if patients have, for example, advanced disease, we downgrade ICD to CRTP. And with discussion of the family, of course, and of the patient.
Okay.
Dr. Hagi, thank you very much for this wonderful lecture. What is your explanation of the decreased number of use of CRT in different countries, despite the fact if the reimbursement already not by the patients, by the governments? Is it the patient delay or ignorance, or the doctor resistance to use CRT, or you don't know how to risk stratify CRT? I know AICD, it's a must, like the pacemaker. I don't think anybody can argue about this. But regarding the CRT in general, I noted that the incidence of the using of this kind of device is not amounting to the different in the coronary. For example, in the coronary patients, the drugs, the devices come up and flare up and then finished. But already that the patient doesn't feel the improvement in quality of life with the CRT early. What's your explanation?
There is two explanations. The first explanation, there is new good drugs which improve quality of life, ejection fraction. So a cardiologist and many practitioners can use these new drugs to improve the quality and the survival of a patient. The second is the cost of CRT, which is still high in our countries. But I think CRT still have its place in the guidelines. On 2016, Danish study some negative results and decreased the enthusiasm of cardiologists. But the new data and the new analysis showed that the benefit of ICD and CRT is still present in patients with good indication, with left ejection fraction and the 35% and left bundle branch block above 120 milliseconds. So two explanations: the new drugs and the cost.
May I add another point, please? Also, the success rate of the patient with CRT, the responder rate is around 70 to 75%, and it's not 100% responders, which is a very important and crucial point. And that CRT devices should be implanted in patients on optimal medical therapy, not to reduce their medical therapy. If the patient feels that he already had a device and he should reduce his treatment, like the diuretics, he'll not feel better, which may be impacted about his general health.
Jill, let's go. Jill, Antoine Lafont.
Yes, my camera does not work. I think I have no access. Okay. I would say that as an internal cardiologist, we can say that the electrophysiology has taken over this part, very important part of the heart failure, and for a patient who is threatened by sudden death, and I would like to acknowledge Dr. Hagi for pointing out people with moderate symptoms who have a higher risk of sudden death. I think it is a very important point. I think we have to acknowledge and to recognize that despite, as you mentioned very nicely, that the symptoms were not improved, the fact to see that you will be protected from sudden death is, for the patient and for the family, something extremely important. And in my institution, I'm surrounded by a team, and it's true that we learn a lot regarding the real indication of CRT.
Okay, Terry.
Thank you very much. I think it was a very interesting lecture. We in my institution, we have a very strong EP team, and they are working hard in this field. They are discussing not with us, but with cardiologists and the clinical cardiologists for the indication.
Okay. Gel Mantelesco? Gel?
Yes. What can I say in addition to what was said already? First, among the limitations, I think we don't see heart failure clinics everywhere, and very few big hospitals have clinics dedicated to heart failure patients where it would seem evidence that these patients deserve CRT. The second point is that lots of doctors take care of heart failure patients, not only cardiologists, and they may treat well the patients with drugs and not be fully aware of what we can do with devices. And it's a huge group of patients now with heart failure. And I think, with all the subspecialties in cardiology, with all the GPs taking care of heart failure patients stabilized by the drugs, many things that they are doing a good job. One, more should be done. So it's a real limitation, and that's why heart failure clinics are important, and all heart failure patients at some point should enter a clinic like that.
Okay. Finally, Amr Zaki, any comment?
It's the same like Dr. Mustafa, because we are working together, all of the three of us. And I think that CRT, at least for my patients, has been lessened a little bit during the last 3 or 4 years because of the sacubitril valsartan, and then we'll add more with SGL2 inhibitor. This has decreased the incidence to have the device.
Okay. I think we come to the end. Thank you, Dr. Hagi. And now I am just to have a closing, just a few minutes closing, and then we have a group photo together. I think this is a very fruitful, wealthy webinar in the last few months in the COVID pandemics, because already it included coronary and heart failure. Gel Mantelesco had a great lecture as usual, and I picked from you that your last slide, which I like it, the 5 items, Gel. High bleeding risk, STEMI, conservative, PCI and conservative, high bleeding risk non-STEMI, no pre-treatment conservative, PCI, high bleeding risk reduced DAP duration, 1 to 6 months, high bleeding risk select antiplatelet, drop in AF, drop aspirin. This is, I think, the message of your talk of 25. Then Terry, calcifications. In the first wave, you have a bifurcation. You have your own thoughts, your own experience now coming to calcification, which we are facing every day. I think you learned from you a lot. Time with you, not doing ad hoc. Learned how to use rotaplators, different balloons, and maybe shockwave in the future in our area. And then Dr. Amr Zaki had a great 4 cases with the controversy between the guideline and the practice, and I know Amr that is usually thinking patient by patient, which is very good, not to stick to the guidelines, but we have to have a guidelines. And regarding ticagrelor for maybe 36 months, and you can take 60 milligram after 1 year, and maybe some switching in some patients. And in calcifications, you can use rotaplator in most of the cases. Then in my talk, SGL2 is coming to stay. DAP heart failure, waiting also for the preservative, and Dr. Hagi regarding the CRT, and I think it will stay. It will stay particularly in at least in few cases in which it's not responding to the medical treatment. Thank you very much, all of you. I think it's a wonderful webinar for 3 hours. I think Paris Saint-Germain is the winner now. It's only 5 minutes for the match, because I'm looking to the match while I'm winking this, because it's a quarter in the match, and Paris Saint-Germain is something to be the winner within 5 to 10 minutes. Congratulations for Paris to be the winner of the final cup.
Thank you.
I know that you have to look at and choose this day. I don't know this is the final cup day, but this is for me it's important to have the French wave, and you promise me please for the wave 3, and then we discuss when to do it. Can I have a group photo? Thanks again to Medtronic and AstraZeneca and ICOM for the preparation and final touch for the technical support.